So I have 3 talks this morning. 2 of them are going to be on vascular, and so they'll kind of be connected. And just here's my disclosure slide. So in this talk, I'm going to speak about a number of things, but particularly looking at endovascular stent grafts and some of the things we do in practice, which becomes an ever bigger part of all of our practices. And if you think about abdominal aortic aneurysms, you know, it's one of those diseases again, which as we have an older population, you're going to see more cases, and radiology is in a really good role in terms of detection and management of these patients. So just in terms of definitions, we'll focus on abdominal aorta, diameter over 3 centimeters, or you can simply look at 1.5 times the normal adjacent aorta. So we look at different numbers, particularly in different age patients. If you look at causes of abdominal aortic aneurysm, classic things: hypertension or smoking, connective tissue disease, and infection. And the first cause is probably going to be the most critical. The infrarenal abdominal aorta is the most common site of aneurysm formation. It's more common in men than women. If you look at some of the numbers, it's truly an aging process as long as you leave out some of the genetic causes. It's felt that over age 60, 4 to 8% in men and about up to 2% in women with the risk factors I mentioned. One of the things, of course, that we recognize now, it's often hereditary, which is why many sites with ultrasound and even CT or sometimes MR are doing screening for aortic aneurysm. So in a family where one relative has had an incidence of a ruptured aneurysm, for example, I'll be evaluating the entire family. Now at Hopkins, we do a lot of genetic diseases. Ehlers-Danlos, Marfan's, and Loeys-Dietz are the 3 most common things we look at. Marfan's was originally described, most of it at Hopkins in terms of the surgery, Vince Scott and Blaylock going way back when. But I won't speak about those. It's kind of a different type of disease process in terms of both the patient ages and the things we're looking for. Loeys-Dietz, our average patient is probably in the 20s. The Marfan's are more the 30s, and the Ehlers-Danlos are in the 20 to 30 range as well, and sometimes even the teen age. Now, if you look for some of the rules are changing, I think, surely in terms of the presence of endovascular stents and the success of endovascular stent placement. It is changing some of the basic criteria about when patients should be intervened on. But here's a typical thing: a fusiform aneurysm over 5.5 centimeters warrants repair. And this is based on the risk factors. A 1-year incidence of rupture is about 9.4% for aneurysms over 5.5 to 5.9, 10% over 6, and 32% for over 7. Now again, one of the things I know when we deal with our surgeons is kind of this risk reward. I think whether it's abdominal aortic aneurysms or thoracic aortic aneurysms, you always kind of look at the risks of repair versus the risk of doing nothing. Other things that become important: the growth rate. So you may have a smaller aneurysm, but if it's a rapid growth rate, rapid being greater than 1 centimeter a year, intervention will occur. Symptomatic aneurysms, patients with back pain or flank pain, and it's really related to the aorta, they're going to be repaired because if you look at some of the literature, that also is an increased incidence of spontaneous rupture. And saccular aneurysms pretty much are going to be considered for repair regardless of their size and symptoms. Now, endovascular repair has really changed everything because it really has changed the morbidity and mortality. There are issues for endovascular repair, surely how the aorta looks, particularly angulation and access points. But with many of the newer endovascular stents, the range of patients that are eligible for stent repair has increased. And in our experience, probably yours as well, almost every patient we see now is getting a stent repair rather than the classic open type repairs. Now, if we step back a second and say, well, how do we evaluate patients? I think at the end of the day, I would say with any or every talk I give, everything in terms of your success relates to protocol. So here's kind of the rules we use. Fast injection rate. You don't need large volumes of contrast. Remember in the old days, people would look at aneurysms at 150 to 200 cc's. Now you can do 100 cc's very comfortably, and in patients who have borderline renal function, you can probably get by with 70 cc's without much difficulty as well. Key thing is injection rate. We use the higher concentrations, typically 350 contrast. In terms of scan delay, it depends how you do the studies. Obviously, in younger patients, a preset delay, let's say 30-second delay, works really well. I think as you get to older patients where cardiac output will vary, then probably a triggering based on a certain attenuation value works very nicely. So for example, if you have a 64 slice or better scanner, if you use a trigger point of say 200 Hounsfield units at the level of the diaphragm, that works very nicely. Obviously, the faster you inject and the faster your scanner is, the higher trigger point you can use. In terms of slice thickness, and this will be the same regardless of the scanner, I like to use the thin sections, 0.75 by 0.5. The overlap is really good on the reconstructions, which we'll show you in a moment. And I think the sub-millimeter thick sections is perfect. You don't need less than 0.75. If you do 1 millimeter, that's okay as well. But I think surely 1 millimeter or less is critical when you're doing reconstructions and trying to look at small vessels. I mentioned that preset delay versus bolus tracking. If you have really good techs, you almost could do it visually, but bolus tracking is the way things are typically going. I just have this picture to make the point, depending what area we're scanning, we do the bolus tracking in different areas. If we're doing thoracic and abdominal aorta, we'll bolus track at the level of the arch. If we're doing abdominal aorta, we'll bolus track typically either at the renal arteries or level of diaphragm. Either works well. And if you're doing runoff studies, then you're going to have a lower trigger point. Typically, we'll do iliac vessels. That tends to work pretty nicely in our experience. Another important thing about all of the imaging we look at is how we look at the images. And obviously, everything we acquire is axial, but it's really looking at the post-processed image. And what I'll show you over the next 3 talks, basically, is how you do post-processing and why it's so important. And it's routinely you're doing coronals and sagittals and often curved planar reconstructions, but also the 3D imaging becomes very valuable. Now, in saying 3D imaging is very valuable, you can't really rely only on the 3D imaging, though I do like the way the images look, and the surgeons like the way they look as well and use them routinely. The biggest thing you want to be careful, of course, is that anytime you do post-processing, you always can introduce error. So no matter how good your post-processing is, you need to look initially at the source data, not to make mistakes. Now, we also talk about the importance of things like bone removal. There's a lot of good software packages that can do bone removal very well. If you have dual energy, we use dual energy. Dual energy, the best advantage to me of dual energy, quite frankly, is the ability to remove bone very successfully and very easily. So you can see in this case, in a patient with multiple grafts, easy to remove bone, or a case like this where the patient has had grafts and has a lot of vascular disease. The automated bone removal with dual energy is very good at not taking too much away. The biggest challenge, I'll show you an example in a moment, is that you can remove things you don't want to remove. And so you need to be very careful, and that's my point about looking at the source data. And we are doing work now in trying to remove calcium. One of the big challenges in vessel patency, of course, is the presence of calcium. One of the promises of dual energy is separating calcium and contrast. But if you use it in practice, if it's a little bit of calcium, it does a great job of removing. But as you get to smaller vessels, particularly runoff studies, often the issue is it'll take away the calcium, but take away some of the flow as well. So it's kind of tricky. You can see here it's pretty nicely done on the 3rd image. And there are new algorithms. This was an article published about 2 months ago, looking at different material decomposition techniques which make dual energy better. Okay, so just remember that. Now, I mentioned the point a moment ago about looking at source data. Here's a good example. This patient has vascular disease, had prior abdominal aortic aneurysm repair. And if you look, the patient's right common iliac artery is occluded. Okay, that's how the images look. And there's nothing looking at that images alone that would make you think otherwise. And here it is just again targeted down. So that would be how you would walk away from looking at those images. But if I go back and look at the source data, here's the patient's aneurysm and repair. And then you come a little bit lower, the patient has stents in both common iliac arteries. And if you look at that right side, there's the stent, and the stent is patent. The computer, for some reason or other, decided it wouldn't recognize the stent and consider the stent as no flow. And so you would have made a mistake. Now you have to be careful because here's the same case, and I'm showing you now MIP imaging. And with MIP, you show the brightest structure, so it's good for looking into vascular calcification, the abdominal aorta. You see the stents and you see flow beyond the stents, but that doesn't help looking at the stents. Or even with classic volume rendering, here are the stents nicely shown, good visualization of the external iliacs beyond the stents, but again, I'm not answering the question here. And here it is side-by-side volume and MIP. We are doing cinematic rendering now, and if you look at the overview of the cinematic, you can see the stents very nicely, you see the flow. But one of the things you can do with cinematic rendering now is create these maps that look inside the stents. And so here very nicely is the patient's aortic repair. Here are the stents, and now you're seeing flow in the left stent and decreased flow in the right stent. It also makes the point in terms of visualization. One of the key things I think for radiology is the ability to deal closely with the vascular surgeons. Here's just a good example. This patient presented IV drug abuser with groin pain. They thought it was an abscess, but we're going to look further, and you can see there's a large pseudoaneurysm. So just to show you the visualizations, once you take the bone away, this is the MIP imaging. So you see the pseudoaneurysm nicely, and you kind of define its relationship to the femoral artery. If you look at that with volume rendering, you can see it as well. Here I left the bone in just to give you a feel of where things are. But there are newer techniques called cinematic rendering, which has a lot more reality to it. The biggest change between classic volume rendering and cinematic rendering is in cinematic rendering, you have multiple light sources. So here's a cinematic rendering. You see the induration in the groin. See some vessels here. Here's a pseudoaneurysm. Then I make the skin very opaque. Then I cut through the skin. Now you see the femoral artery. You see it's compressed. Here you see it's compressed and narrowed. You can see exactly the pseudoaneurysm. Here I took away the bone and show it to you. And here is what we typically would give the referring physician, which would be the images with motion, so you can basically rotate the images around in real time and get the optimal view, and you can see the narrowing of the femoral artery here. So again, it's very important for us to recognize that a lot of the information that we provide to the referring physician is not whether or not there's an aneurysm, a pseudoaneurysm present, but it's the close relationship to vessels and precisely what needs to be done. So the mapping becomes very critical, recognizing there's pitfalls, and so when I do the 3D imaging, I look at everything sort of as a composite. Now, if we look at endografts, what do we need to know? So in terms of protocols, routinely in CT, except for renal masses, we rarely do non-contrast studies, but when doing follow-up stents, we always do non-contrast because you may see high-density material that could confuse you with the leak if you didn't have those images. You can do very low density, very low radiation dose, rather non-contrast scans. People have written a lot about dual energy with contrast subtraction, but that has not worked as well in our experience, so we'll just do some non-contrast through the region of the stent. Then we do arterial phase imaging at about 30 seconds and delayed phase at about 80 seconds. Typically, what you'd like to see when you have a stent repair is the aneurysm decreases in size over time. There's no great numbers to show the rate of decrease, but it needs to be either stable or decreasing in size. And then, of course, you're going to look from complications. The most common complication we look for are endoleaks, change in stent positioning like migration and kinking, I'll show you some of those, and branch vessel compromise, as well as other complications. So here's just a simple example, baseline endovascular stent. You can see the size measurement here, and then you see that 1 year later, you can see it's decreased in size from 6 cm to about 4.5 centimeters. So that works out very nicely. When we talk about complications, we talk about immediate being under 30 days, short-term 30 days to 12 months, and long-term over 12 months. Most of the complications we do see are in that short-term 30 to 12-month range. If we try to look at the types of endoleaks, type 2 is going to be the most common. Type 1 we see more when we see stents in the thoracic aorta, typically from an inadequate graft apposition at the proximal and distal zones. Type 2 is retrograde flow, usually from a iliac artery or a lumbar artery, the most common. We talk about type 3 from inadequate graft to graft apposition. We see that less frequently now as we do a better job sizing the endovascular stents and they're better constructed. Type 4 is flow through the pores of the fabric. That's something that's not uncommon in the immediate post-op state, but usually we don't see that very often. And then type 5 would be a refractory occult endoleak, where you don't see an endoleak, but the aortic size is increasing. Then device failures of migration or enfolding, and we'll come to some of those. The key article written on stents was written about 7 years ago in New England Journal of Medicine, where they really looked at whether endovascular stent placement would change the morbidity and mortality compared to open procedures. And at that point, the stent graft industry was relatively new, but even then it appeared that endovascular repair led to increased long-term survival among younger patients, but not among older patients. Now, of course, they thought that it would be better in older patients, but these patients often had many comorbidities, but it was giving longer survival and less complication. And if you look at the articles since then, it basically is pretty much shown, this article from Hopkins, that basically at endovascular centers, and again, not surprisingly, the number of complications relates often to the skill of the surgeon. High-risk patients should be considered for aneurysm management in dedicated aortic centers. And in those centers, the risks of complications typically is very low. And although survival numbers may not change, we are seeing increase in survival and surely decreasing complications in older patients. So let's look at some examples. I mentioned type 1 endoleak, proximal distal stent, not a complete contact with the aortic wall. And it's often a sizing issue. Gap between the stent and the wall allows blood to flow into the aneurysm. And here's just a good example of a type 1 endoleak. And as I mentioned, you can see it here, there's an abdominal repair. Most of the time we see it, it's going to be thoracic aorta. Type 2 are the most common. Type 2, up to 20% of patients have type 2, particularly if you look at patients 3 to 6 months out. I think as you go a little bit further out, the type 2s tend to be often resolve on their own. I mentioned we do arterial and venous phase imaging. Sometimes you'll see the endovascular leak only on the venous phase. And it's been written that if it leaks on the venous phase, it probably is more important. Here's just a good example. On the arterial phase, you see the type 2 endoleak. If you look hard, in many cases, you can see the source of the feeding vessel, which may be embolized. And in this case, you can see very nicely that as you go to the venous phase, this is about 80 seconds out, the endovascular leak is even more impressive. And so patients who have that change from arterial to venous, the likelihood of that endoleak resolving on its own is significantly less. And here's just another example. And surely if you have a case like this where you have an endoleak and the aortic aneurysm is enlarging over a 1-year period, intervention will be necessary, because if you do nothing, here's a typical thing that will happen. You'll begin to get, in this case, the patient's developing a rupture as the aneurysm was increasing in size. Sometimes patients present with back pain, and here's a good example. Patient had back pain. Everything went well in this patient, supposedly, but now you see some blood, fluid in the retroperitoneal space. and you scan a little bit lower, look at the size of that aneurysm. So basically, this patient had repair, but the repair failed, and you can see this large aneurysm. This increased in size from roughly about 6 centimeters to what's about 15 centimeters in a 3-month period. So often the expansion is not just a gradual process, but something that happens. And you can see here very nicely, it's interesting, on the very early phase, you don't see active extrav, but here you see it very nicely on the venous phase. So again, it's hard to predict, but as I mentioned, when you see it on the venous phase, it's going to be worse. Type 3 endoleaks, poor seal between the components and frame component separation. Type 3 will always be treated. Here's just a good example, non-contrast scans. The aneurysm was enlarging compared to the prior study. And here it is with contrast. You see going right from the stent itself, right here. And you can see it a little bit better as you go through the images. You looked at the last image, perhaps it was only a type 2, but here you can see very nicely exactly where the leak is within the stent graft material. And here it is on the 3D mapping. So I think creating the 3D maps can be very helpful. Here's just another example, a very similar appearance, and this is with cinematic rendering. So in terms of often defining the specifics of the leak, the 3D maps can be very helpful. And what I'll try to do is create a 360 presentation to show that. And you can see often the rendering. So this is the same image. Here we're rendering toward the blood, so you can see the leak here. Here I simply am optimizing for looking at the material of the graft proper. Type 4 endoleaks are typically in the 1 to 30 day period. They typically do resolve and are self-limiting. Type 5 are the things we worry about. Now, one of the important things about doing studies is measuring the same measurement point at each time. One of the things that people talk about AI doing, and some of the early AI stuff, is very simple. It simply does measurement. It's been shown that physician measurement tends not to always be reproducible. And so, for example, if you have a report that says it was 4.9 centimeters, and you measure now and it's 5.2, one can say it's expanding, but if you don't have the films in front of you and you don't see what was measured, you're never really quite sure, was the measurement done correctly or am I measuring the same point? So you need to be very, very careful. In this case, it went from 6.9 to 7.1. You were measuring precisely the same point, and then it went to 7.6. And it was just simply followed, and you can see here the patient presented with a rupture of that aneurysm. We talk about device failures. The good news is with the newest grafts, it's less frequent, but here's a typical appearance. Often with the failures, you need to either look at the coronals or the 3D. You can see the graft here, the sharp angulation, which is shown nicely on the 3D mapping. And you can see very much what's happening is basically it's a migration and an infolding of the graft, nicely shown here. Or in this example, this patient presents with back pain. Look at the bleed in the retroperitoneum. You see the large aneurysm. You can see right there the patient's leaking aneurysm. And then as you track it down, you'll track it down to the stent. And what happened was the stent failed. Look at this 90-degree angle right here. The stent basically is crumbling, and then the back pressure led to that patient's aneurysm increasing and the contrast extravasation. You can look at this a little bit better if you wanted to look at this and straighten it out. Things like curved planar reconstruction can be helpful, but you can see here as well very nicely the very sharp angulation. Another example, again, looking at the images alone, you kind of see some overlap here, so something has to be problematic, but surely it's easier to see in the coronal view, right? There's the very sharp angulation. And that's stent failure. The patient will have to have a redo procedure and some bypass grafting in that regard. Here it is as well. It's interesting, sometimes the patients will be symptomatic. Many of the cases, simply it's on the imaging. So our routine for patients is typically 6 month and 12 months follow-up, and then yearly if things are going well. But this is just a good example. This patient was relatively asymptomatic, and we called to tell the surgeon, and they were surprised because they felt that there was no issues. Another example here, this patient had back pain and swollen lower extremities. Here you can see in the non-contrast, something looks wrong with the stent, and the stent is failing, and now it's compressing onto the patient's IVC. You can see, look at the stent failure here, and now the aneurysm was enlarging and compressing the IVC, which explained the patient's lower extremity symptoms. And you can see as I go through the images, the expanding aneurysm and the failure of the stent. And I do make the point that the 3D mapping works very well. It's much easier for us to understand what's going on, and it's much easier for the vascular surgeon. Trying to do descriptions based on the axials is really hard. I think here you can quantify and be much more specific. Device migration, again, the biggest issue tends to be wrong sizing, and so here's just a good example. The device migrated, and now you're seeing this infolding and buckling, and the aneurysm is going to increase in size. This patient will need a redo procedure. Now, people talk about branch vessel occlusion as one of the complications. The reality is particularly in patients with multiple renal arteries, it's not uncommon to get branch occlusion of renal artery branches, and we see that all the time. You can see very nicely, here's a typical appearance, nice renal cortex. Here is decreased enhancement and loss of cortex. And invariably, it's small accessory renal arteries. Here's another example, stent placement went well. Here is decreased perfusion, lower pole right kidney, mid portion of left kidney. Here it is again. So it's not really going to be uncommon. Here's another example, non-contrast scans. Patient has a stent put in the renal artery. Patient has a type 2 endoleak, but also has multiple renal infarcts. Now, most of the time, the renal infarcts will be managed conservatively, and there's not much you really can do about it. Here you can see a good example of this lower pole renal artery going right to the region of infarction. Undoubtedly, there's narrowing where the renal artery came in. You really can't preserve those smaller renal arteries, and the surgeons are willing to sacrifice, particularly the small vessels. In terms of long-term renal function, it really usually is not problematic. There have been several articles that have made this point that it's not uncommon. Up to 1/3 of patients experience a transient increase in creatinine levels in the immediate post-op period, and up to 4% can require temporary dialysis. But the patients who have real problems is when the main renal artery is injured. And so the surgeons are very careful from the initial imaging. If the main renal artery is going to be covered or potentially covered, they'll put a stent in there, and that works out very well. So this mild increase in creatinine levels usually is not going to be something people do worry about. Now, another problem is infection. Fortunately, it's infrequent, but it does occur. Here's a typical example. Patient was febrile. This is about 6 weeks out. You see the left pleural effusion. I always worry when I see effusions and things going on in the lung. And when you see an air bubble more than a week or so out, I am concerned. And so this patient has an endoleak, but these air bubbles here, this was infected. The patient developed an empyema. So if I see air bubbles around the aneurysm and things like consolidation, or in this example, you can see air bubbles, you see fluid around, that's going to be infection. That would typically be drained. Or in this case, this is a couple months out, you see an air bubble here, patient's febrile, the stent infection, and now this thrombosis of the stent. We also look for complications, and one of the most critical is aortic enteric fistulae. Aortic enteric fistulae aren't all that common. It used to be described as something where you would have an enlarging aneurysm, and it would involve the third or fourth portion of the duodenum. Now, that's still the most common area, but invariably it relates to the fact that the duodenum comes very close to the aneurysms, often abuts it, but every once in a while you develop this communication. Now, it's rare to see contrast contrast, going from the aneurysm into the duodenum, truthfully, patients like that typically will exsanguinate, and you're not going to see very often. It's a life-threatening disorder. Primary and secondary forms, the most common is going to be post-repair, not just a native. And the classic findings are abdominal pain, GI hemorrhage, and pulsatile abdominal mass. Things you look for: air within the aortic lumen or adjacent to the aorta, the direct contact of the aorta to bowel. Now again, you may see that in normal patients, but you look very carefully for the presence of air, focal bowel wall thickening, or even potentially obstruction. Here's a dramatic example: patient with back pain. Look at this aneurysm, which was increasing in size. You see all the air bubbles. That's the duodenum. This is a direct communication between the aorta and duodenum. This patient underwent emergency surgery. This patient did not survive. Another example here, not as dramatic, but you see multiple air bubbles, and you shouldn't see air bubbles a few months out. You can see very nicely there and there as well. And here's one more example of a patient who had a failed stent, had a redo of the stent. One limb was occluded. You can see the duodenum is sitting right on top of it, and the patient presented with GI bleeding. And I'll speak about GI bleeding later, but one of the causes in a patient who has a stent is these aortoenteric fistulae. And here's just one last example: back pain. Look at this fluid collection back here. Here's the duodenum. So a very nice example of aortoenteric fistula. And they can indeed be very impressive, like this example. And here's a sagittal view of that. You can see the mass effect. Patient had back pain. I've seen patients also occasionally present with osteomyelitis, but that's very rare. So concluding then, endovascular stents are really the future of vascular imaging. I think as a radiologist, we need to work closely with the vascular surgeons, understanding both what information is needed pre-op and looking for the complications post-op, and protocol becomes very critical in making this happen. And with that, I'll thank you very much for your attention.